Good morning, everyone. My name is Abdel Salam Al Askari from Egypt. I would like to thank Dental XP for having such a wonderful platform um, that is really concerning education. And my topic today is kind of new. It's the treatment of gingival recession around dental implants. I'm sure that most of you have faced such problem in your office, and I will try today briefly in the time constraint that we know that I will try to cover this as much as I can. I'm sure that most of you can transform a case from here to here just with the use of the regular implant dentistry methods. In those immediate implant placement cases really do very well as we can see here, and I think the general dentist now is able to perform a wonderful result as we can see here. However, the question is, if we have four implant supported restorations like this, and how long can we offer a promise for the patient for an aesthetic success? How long this case will survive? This is a follow-up from September 2008 to November 2010, and you can see the related recession to the implant sites here. Well, that's a problem that we really need to face, we really need to define, and we need to know why this occurs. There are so many factors that are concerned with this phenomenon. There are some physiologic factors that we really don't have any hand on it, like post-extraction resorption, the thin nature of the labial plate of bone, the thin tissue phenotype, and etc. And there are some technical factors, plenty of technical factors, faulty implant position, which is the major contributor to recession, and the excessive load, thin and faulty tooth brushing, the use of the smooth color of implants, and pressure from prosthetic modules, and etc. Plenty of factors. Knowing also when we do an immediate implant placement, not most of the cases, on the contrary, almost 70 to 90% of the cases either have lost labial plate of bone or very thin labial plate of bone. That's really something that we do not have any hand on. That's even a major contributor to recession. Now, if we have cases like this is very thin labial plate of bone, I would not hesitate at all to change this profile to that profile here. I double or triple the thickness of the labial plate of bone, and then I really properly select the right implant position in order to maintain a long-term success for this case. So this is really what we do in present for these situations. The phenotype. Cases like these, when you follow up a case from 2002 to 2007, and you can see the tremendous change in the tissue and in the apical migration of the soft tissue, thinning of the soft tissue like this is something that we need to watch. This is the influence of the thin scallop tissue biotype and or phenotype per se. Now, if we have really such case like this, we need to think twice or three times before doing immediate implant placement. We have to do many things before getting into dental implant placement. Now, if we have a case like this, just to show you the influence of the thick or the flat phenotype of the tissues, bone here is void. We can see that there is no almost half of the labial plate of bone is going around this implant. However, we can see there is no recession here. So why is this happening? Why? It's just simply because the quality of the keratinized tissue, the thickness of the phenotype, and the flat labial profile of the tissues. Those are the things that really plays an important role in the gingival recession around dental implants. When we do cases like these, big reconstructive cases with membranes and bone and etc., those cases, they might show an immediate, bright, successful result. If you follow up these cases on the long term, then you can see what's really happening. So the post-regenerative bone resorption is also another factor that we have to keep in consideration. This case should have been provisionalized with a provisional restoration for minimum 1 year. That is one of the faults of the speedy installation of the final prosthesis. Now, implant position. Poor implant position has two components, either too far labial position or too deep implant position. Both of them really contributes to the recession. The labial, too far labial, as per stated in the literature, it really showed 3 times more recession than implants placed in palatal position. This is a major player in contribution to gingival recession related to dental implants. Now, what about the treatment options or those philosophy of the treatment for gingival recession? We really think that there are some steps. I developed a protocol that involves very accurate soft tissue preparation that might be separate, staged or non-staged approach, and then decontamination of the implant surface or removal of the implant surface, and the graft procedure itself, and then the bone preparation, or both together. These are the 4 steps that we really use. I will show you some cases for that. But before I go with that, I'd like to mention one thing. If you have a recession only on the labial implant surface, then we can get away with the grafting procedure and soft tissue modification to cover up for this area. But if you have such situation, when you have both labial and lingual plated bone are receded, and if you have this classic situation, there is no way to keep this implant. I think the best is to remove this implant, rebuild the tissues, and then come back and place another implant, or you place it at the same time. Another important factor, if you think that coronal repositioning flaps will do any achievement for recession, I think you're wrong. I think we are really wrong if we think that coronal repositioning flap will improve gingival recession. We'll never do this around dental implants at all. This is something that we have tried so many times and it failed. The only thing that I highly recommend, and I use it on constant basis as a standard protocol for the treatment of gingival recession, is the double papillary approximation flap, as you can see here. This is the diagram that's showing this procedure. I'll share it with you in a while. And now let's get to clinical applications. The clinical applications, I start with first the non-invasive methods or the non-operative methods, which are plenty: platform switching and less frequent abutment removal, and then the preservation of the biological width, the use of laser-etched collar implants, I'll share with you in a moment, and the prolonged use of the provisional restorations. This is a very important point. And then the routine use of connective tissue grafts with each implant installation. This is one of the problems with the use of the smooth collar implants. As you can see here, thinning of the soft tissue, and then the metal show through the thin tissues, as you can see here, as a result of the smooth collars of some implants. Now we really use the platform switching. There are new implants in the market that really have a lot of scientific evidence as well as histologic evidence of soft tissue attachment to the laser etching of the abutments as well, and the implant collar. So I suggest that this will perform a major contribution to the stability of the soft tissue margins for the future. This is one of the really wonderful designs that I really appreciate, and we're conducting so numerous studies on this platform switching with the laser etching surfaces to stop gingival recession around implants. What about these cases? A case like this, when you have wonderful margins, no recession, and then when you just place your crown or your restoration, tissues start to creep up, tissues to start to push up. Why is this happening? Why do we have this? Simply because we violate the biological width. There are some cases that do not really tolerate the pressure from the prosthetic margins. So we really prefer to keep our margins, in some cases which has thin tissue biotypes like this, supragingival or equigingival margins. Really, we we have seen so many cases that have a recession just because of the pressure of the margins of the prosthesis. Now, we have also pre-existing recession. Before placing the implant itself, we can start with recession like cases like this. Now, we can see that there is no bone here. There's hardly we have labial plate of bone. Then the procedure, as I have really placed here, is to get rid of this frenum first. So I thought that if you get rid of this frenum, and then you probably have a better vestibular width, and then remove the pull that would probably be exerted from the muscles of mastication. Then this is the design of the soft tissue drape improvement, which is the double papillary approximation with the removal of the scar tissues here. And then I will go with the surgery. I'll prepare first my pedicle connective tissue graft on the palate, and I move it subepithelially, of course, and then I move it up forward labially. This is the double papillary approximation. We suture these cases together, as you can see here. This is the sutures. I suture also the pedicle flap to the labial side, and then I release my flaps in order to allow for a soft tissue free tension closure. And as you can see right there. Then we carry on to the healing. This is when we start. This is when we ended up with my just 2-3 weeks post soft tissue amendment, and this is the result is evident here with the improvement of the keratinization and the improvement of the width of the mucosa. This is also another problem with that patient that happened, which is the lack of the space. You can see here there's no space, there is no restorative space. So we went to the orthodontist to improve this space with one device that he placed for this patient. Then the case started to move from here. We developed the space gradually until we have a sufficient optimum restorative space for this patient. Then, when we went to the surgery, we started to discover the amount of labial plate of bone resorption. So we started to place the implant according to the three-dimensional positioning protocol. Then we grafted the labial defect with sonic weld membrane. Then this is also another membrane that is called, I think, it's a cellulose membrane that we put just to facilitate the adherence of the soft tissue to the underlying grafting mixture. This is another releasing of the periosteum just to allow an enhanced and tension-free closure. So this is, and then we placed another connective tissue graft just to allow for a better soft tissue adherence. Now, this is, we can see, this is at the time of suturing. This is just a couple of weeks later on, and this is 2 months, and that's the final healing with the healing abutment removed. It's a little bit overdone, but we know that with the time, this will go back to its normal position or normal contour. This is a CBCT scan showing the improvement of the labial profile and the complete regeneration and acceptable thickness of the labial plate of bone. This is a zirconium abutment that is being placed at the time of impression making, and this is the soft tissue profile. Then we move the case from here to there with a zirconia crown. Beautiful and acceptable result with a strong soft tissue support for this case. Then happy patient, and then probably a long-term success against recession. Now, when we move to cases like these which have a minor recession with around dental implants, I would suggest to use just a connective tissue graft for those minor cases. Very easy subepithelial dissection or supraperiosteal dissection, and the placement of a connective tissue graft will really do very well here, and it proved to be a very good treatment for just minor types of recession. And we can see here the improvement of the labial profile in both sides. Then we can really restore this case with confidence. We move this case from here with thin labial profile to a better labial profile that resists any recession in the future. And that case that I showed you in the beginning, here is what we have done with this case. We just gave this patient with a crown in place a subepithelial connective tissue graft stabilized with resorbable sutures, and we managed to really cover this recession. However, I just would like to mention that cases like this, when you have class 2 recession or maybe over than 1 or 2 millimeters of recession, any soft tissue procedure that you will do will never get any success. So just try to use those soft tissue procedures only for the minor recession cases. When we get into class 2 recessions like here and implants that is totally receded with 5 to 6 millimeters, then we will go to the radical treatment type of treatment. Here is the soft tissue drape repair design with the double papillary approximation design. Here is the first we harvest the pedicle subepithelial connective tissue graft from the palate. We rotate it to the labial side in order to improve the labial contour and to get a backup for my double papillary approximation. This is a standard protocol that I do with these cases. So this is the double papillary approximation as a standard protocol for these cases. I use any thin suture like 0.5, 0.6 sutures will do very well here, just not to pierce the flap tremendously. Then I will rotate my pedicle underneath this flap, and then I will allow for soft tissue closure and move on at the same time of the surgery with the implant removal and then the bone graft stabilization. Here is the defect after the implant was removed. I harvested a little bit of bone from the site and just to mix it to allow a particulated type of bone graft, which I really think that it provides very good osteogenicity for my graft. And then I covered this graft with a sonic weld membrane stabilized, and then a connective tissue, a collagen membrane stabilized with those wonderful membrane tags from BioHorizons. Here is the connective tissue graft stabilized from the palate, and then the final closure. Now, here is the preoperative cone beam CT. You can see here the lack of the labial plate of bone, and then this is 2 months post-healing, wonderful soft tissue repair, wonderful bone structure labial to the implant that would resist any future gingival recession. I learned this technique from Maurice Salama personally. Yes, I do I really confess that, and I think it's a genius procedure. I just use my burr just to remove the epithelial layer, and then I just use my scalpel as a semilunar incision to harvest a pedicle connective tissue at the site, and then I rotated inward and upward just to improve the soft tissue contours here labially, as you can see here. And then I place my healing abutment. This is the labial contour amended, beautifully situated, and I think now we are ready to go for the prosthesis. I think that we have done almost 100% of repair for the recession for this case. This is the case preoperative, and this is the case postoperative at 1 year follow-up. This is a 1 year follow-up, stable margins, no recession whatsoever, excellent result. Now, when we move to the last case for this webinar, I really think that this is one of the hardest cases in class 2 recession when you have over 5 to 6 millimeters of implant is exposed. This case we have done 13 years ago, I think. Then we had to remove this whole structure and let this area heal. When we let this area heal here, we discovered that we have a deficiency of soft tissue keratinization. We have a low vestibular depth. So we had to work on the soft tissue separately. When we look at the CT scan, we look, there is no bone. Almost we need to build up all of this labial contour. As you can see here, very poor atrophied premaxilla. And then we work on the soft tissue drape first. As I told you before, I used here vestibuloplasty and onlay keratinized tissue graft. This is 2 weeks healing, beautifully healed, and the vestibuloplasty is really have done very good in terms of the widening of the vestibule, and the keratinization here is what we really look for. Now we move after 2 months to surgery time. Look at these thin ridge, very thin ridge, and you can see here, and I managed to put 4 implants here, and with dehiscence that I will repair for later on. I prefer to use the non-staged approach all the time. I don't really go for the staged approach. I always use the non-staged approach just to help minimize the number of surgeries and to minimize the number of the tendency to recession, the tendency to stiffness of the soft tissue. Here is the template that I use first before I use my membrane. I just tail my membrane later on and stabilize it with those thermal screws, resorbable screws. This is a PDLLA membrane from Sonic Well. And then I placed my particulated bone graft material underneath, and then this is a cellulose sheet on top of that to facilitate the adherence of the soft tissue. The thin ridge, as we can see, and we can see here the dehiscences around the implants. I tried to harvest some of the bone chips from the local area here without having to go for another surgical site, just to enhance my bone graft mixture to be particulated with those autogenous chips. This is the membrane positioned, and you can see here, this is the bone graft material being condensed underneath this membrane, and then I keep on condensation until I fill the whole area. And the secret here is to really have a stabilized grafting complex. If you just lay your membrane like this, it will wobble, and then it will really move underneath the soft tissue graft. Here is the closure, beautiful closure, tension free. This is the pre-op CT scan. This is the post-operative CT scan. You can see here the restoration, complete restoration of the labial profile. Beautiful. Herefore, you can expect a beautiful healing and a beautiful vestibular depth, as well as good keratinization at the ridge area. This is for up to the standard protocols. It's an acceptable aesthetic result that really has abundance of keratinized mucosa. You can see here, we will do then some of the site development at that area. This is before and after, and this is the pontic development at the site. Beautiful, stable. We let it heal for a long time. We use a lot of provisionalization methods here in order to stabilize the tissues before taking the final impression. Then we reach this. Then if you compare the picture before and the picture after, you will appreciate that we were able to move this case ahead and forward against recession. Well, before I go, I just want to give some conclusions before I just go. Number one is that the treatment with the gingival recession is not a standard one. Every case is a single case, and it needs to have an individualized approach. There's no standard really protocol for this, for these types of cases. Number two, I need to identify the condition of the labial plate of bone, the soft tissue phenotype, which is the major player in the treatment success. And then the soft tissue solutions offer success only in minor types. Don't think of any coronal repositioning flaps or whatever, because they don't really offer any success. I really believe that the main key behind the success of any regenerative related surgical procedure is the soft tissue handling. Soft tissue handling in all terms, in all steps of the treatment. The key is the soft tissue, not the real regenerative procedure. At this time, I would like to really thank you very much for being here, and I thank BioHorizons and thank Dental XP, for giving me the opportunity to speak today in front of you. And you have a great day, all of you.